So, without further ado, let's watch a brief report from the ESC on some exciting new data in coronary artery disease.
Signify is a large randomised study checking the impact of heart rate reduction by ivabradine in patients with stable coronary artery disease who didn't have clinical heart failure. Signify results were reported by Professor Kim Fox at an ESC 2014 hotline session simultaneously with their publication in the New England Journal of Medicine.
The purpose of Signify was to show if reducing heart rate with ivabradine would improve the outcome of these patients in terms of cardiovascular death and non-fatal myocardial infarction. The answer was that it didn't. There was no reduction in cardiovascular death and non-fatal myocardial infarction by reducing heart rate and aggressively reducing heart rate as we did in Signify. There was an improvement in symptoms, in terms of the symptoms of angina, and there was, in the people with angina, there appeared to be a slight increase in cardiovascular death and non-fatal myocardial infarction, which is being currently explored by the regulatory authorities. We really had thought that heart rate was responsible for the progression of coronary artery disease, and now we know that's not true. The practical message is, first of all, if you want to use ivabradine for angina, yes, do. It's an effective anti-anginal, and be sure that you use it in the correct dosage as laid down in the SPC, that is 5 milligrams twice daily to start with, up to 7.5 milligrams daily twice daily, and do not use it in the way it was used in Signify. Also, be very careful of the concomitant use of particularly verapamil and diltiazem, which will further add to bradycardia.
So, Signify was a huge effort by a large number of investigators. Professor Steg, just remind us, what was the rationale behind this large trial?
Well, there were two main ideas. The first one is there's a wealth of epidemiological evidence from many studies linking an increased heart rate to increased risk of events in patients with cardiovascular disease. And specifically, there was data from the placebo arm of the Beautiful trial showing that among patients with coronary artery disease, it seems that the greater the heart rate, the greater the risk of coronary events and cardiovascular death. In addition, the Beautiful trial was a trial that tested ivabradine in patients with coronary artery disease and left ventricular dysfunction. That trial completed a few years ago and was overall neutral, but a post-hoc analysis in patients with angina and a heart rate above 70 beats per minute showed that this subgroup appeared to derive great benefit in heart rate lowering from ivabradine. And that suggested that maybe testing this post-hoc observation prospectively in a group without left ventricular dysfunction or heart failure might show conclusively whether there's benefit in this.
And you went to all of that effort, enormous number of patients, 19,000 patients. So this is a big, important study. And just remind the viewers of the overall result of the trial.
Well, the overall result is neutral. There is no benefit of ivabradine in slowing the heart rate in these patients with coronary artery disease and no heart failure. No benefit on cardiovascular outcomes on the composite of death, myocardial infarction, even though there's a genuine difference in heart rate. The heart rate is approximately 10 beats lower in patients receiving ivabradine compared to placebo on top of optimal medical care, all things being equal.
So picking up on that, Professor Ferrari, effective heart rate lowering with ivabradine, we know it works very well at dropping heart rate and sinus rhythm, but completely neutral results. How do you explain that?
Well, you said completely neutral results, and that obviously is a disappointment, particularly when studies with 19,000 patients. But disappointment does not mean that the results are not interesting. And I think personally that the results of Signify are extremely interesting from the physiopathological point of view, because the question that Signify was testing is whether or not heart rate reduction is able to reduce the progression of atherosclerosis, to reduce the thrombus formation in the coronary artery, or the rupture of an atherosclerotic plaque. And the results of Signify are telling us that that is not the case. In addition, we questioned many times whether increased heart rate in a coronary artery disease is a risk factor or just a marker of the disease. And Signify is telling us that is a marker of the disease. And from the physiopathological point of view, this is very important.
So interesting result, but slightly confusing on first looking at it. And I think in the subgroup of patients, a large subgroup with angina, there actually seemed to be a hint of an increase in event rate. Was that true? And how can we explain that? I'd like both of you to give me your opinion on that. So Professor Ferrari first.
Yes, you said rightly confusing, because there was so much expectation and was so much, let's say, logical to have positive results that we need to think over these results. And particularly for the subgroup of angina, I have three mainly explanation. And actually the explanation is multifactorial. You have to put all this, at least these 3 points together. First, in Signify, we use a higher dose of ivabradine than in all the other studies. We started at 7.5 milligrams twice a daily, up titrating to 10 milligrams twice a daily, and 52% of the Signify patients receive this very high dose of ivabradine. The second point is that in Signify, more than 1,100 patients received as a concomitant therapy either verapamil or diltiazem. These two calcium antagonists not only further reduce the heart rate, but also they inhibit the cytochrome, which is important to metabolize ivabradine. So these patients were exposed to higher dose of ivabradine, and that caused more bradycardia. I'll give you an example. 18% of the patients in Signify experienced bradycardia, and only 4% in the patients in Beautiful, which was the reason why we did Signify, experienced bradycardia. When you put all these 3 components, you can explain the results that we got.
Thank you. And Professor Steg, do you buy this argument? Or maybe it was just chance. Beautiful was positive in that group, Signify was negative. What do you make of it?
I think the angina group is interesting. There's a positive and a negative finding. The positive finding is that the anginal symptoms were improved in that group, and in fact the need for revascularization was decreased. So the symptomatic benefit of the drug is there. That's the reassuring part. The unexpected part is that in complete contrast to what was seen in Beautiful, instead of deriving a greater benefit, that group appeared to have a signal for harm. Now, we always need to be cautious when we're interpreting a subgroup from an overall neutral or negative trial. That being said, there is a statistically significant interaction. I think it's worthwhile exploring the data in more detail to try to understand and tease out which are the factors which I think are not conclusively identified yet, but there are hints around which was identified. I think we also need to account that this may be a chance finding.
What struck me about the trial was the event rate was actually very low in these patients, which is good news for patients that actually with chronic coronary disease, with or without angina, they're at low risk. Remind the viewers about other drug classes we use for angina. What's the evidence base for them? It strikes me that actually this is a much larger trial and evidence base than we have for other therapies. Professor Ferrari, I'm looking at you, yeah?
Okay. Well, I mean, there are drugs which in angina are able to improve prognosis. It's quite important to state very clearly that in angina you treat the patients with drugs for symptoms and with drugs that we know can improve the prognosis. These two classes of drugs that can improve the prognosis are the ACE inhibitors, and actually I should say that the evidence is just for perindopril and ramipril from Europe and HOPE, and the statins. All the other drugs that we are using is to reduce symptoms. And between these, there are also drugs that are reducing heart rate. And as Gabriel said, in Signify, there was a good symptomatic effect of ivabradine, no question about that. For instance, you take the beta blockers that we are using in angina to reduce symptoms, and we think that they can also improve prognosis. But that is an extrapolation from data maybe from heart failure or maybe from post-infarction patients. And simply we do not know that. That is the beauty of the Signify trial that has put some light on these questions.
So taking it to the practical level, when you've got a patient in front of you with coronary disease, with or without angina, has this trial made a difference to the way that you treat your patients?
Yeah, I think, first of all, to me, I view it as a call to arms for doing further studies with the other anti-anginal agents, because as Roberto Ferrari has highlighted, we have evidence that these agents improve symptoms, but there's really no evidence that most other anti-anginal agents improve outcomes. Even the beta blockers, we're not really sure. In fact, there are a number of observational studies from our groups and from other groups that actually suggest that there might be no benefit, if not harm, from other anti-anginal agents. So I think that's, to me, it's an awakening, a wake-up call that we need to really study the outcomes in these for these other agents, and we will need to do this in a more creative way than we did conventional trials, probably for less money, in a simple and maybe registry-based kind of trial, as the Swedes have done for other things. They're showing us the way of doing simpler and lighter studies. Now, with respect to practical implications, I think that we know that ivabradine improves outcomes in heart failure, and we'll come back to that, I'm sure, in a few minutes, so that's a compelling indication. With respect to angina, I think when we're faced with a patient with angina and he or she is not relieved by conventional therapy, we have to balance the symptomatic benefit and the signal for potential outcomes harm that we see in Signify until we further understand it. And certainly, if we use the agent, we have to be extra careful to start at a low dose, to not use any heart rate lowering agents such as diltiazem or verapamil that have an interaction with ivabradine, and monitor the patient carefully.
And we'll come on to heart failure in a moment, and I'll bring you in there, Professor Comasta. But it strikes me that actually the amount of underlying LV dysfunction is hugely important in terms of heart rate, and it's important in mechanism. So, Professor Steg, do you think that's a crucial factor in decision-making? And what do you think the biology is that's driving that? And then I'll come to you in turn on that question.
I think Professor Ferrari has given this more thought, but in our discussions, to me, it's really apparent that we've learned from putting side-by-side Shift and Signify that the significance of increased heart rate on outcomes may be causal in one case, in heart failure, and probably purely a marker of risk in coronary artery disease. And I think there are a number of hypotheses to try to explain why this is so. But really, I think that since ivabradine is a pure heart rate lowering drug, it's actually a fairly compelling argument to say heart rate lower. It does one thing: heart rate lowering improves outcomes in heart failure, does not improve outcomes in CAD, and therefore the mechanism by which you have increased heart rate, particularly neurohormonal activation, present in one case and not the other, might be crucial in determining the benefits or lack thereof of the intervention.
And Roberto, do you agree with that kind of pathophysiological explanation?
Fully agree, and I'm coming from basic science, so at the end I'm really excited about the results of Signify. Because, you see, if you have a damaged ventricle, like in heart failure, the increase of heart rate is a compensatory mechanism which in the long run may be detrimental. And as the group of Professor Comasta in Shift showed, for instance, reducing heart rate reduces the afterload and therefore improve the so-called remodeling model. So in heart failure, reducing heart rate has beneficial effect on the damaged ventricle, and therefore is an increased heart rate is a marker and a risk factor at the same time. Now, when the ventricle is absolutely normal, there is not much that reducing heart rate can do on the ventricle, I told you before that heart rate, and that's as shown by Signify, cannot do anything on the coronary artery. So because the heart is made by myocytes, which are pumping, and the coronary artery, which are feeding the myocyte, there is not much that we can expect in terms of prognosis. And therefore, when the ventricle is normal, an increased heart rate at the best is a marker of the disease. Now, it seems very easy to say this now, but I couldn't anticipate 3 years ago when we started the Signify, and it's very clear to me today.
So confidence now because we've done the trial.
Absolutely.
And we've got the data.
Let's make the point that we need to do the trials, and even if the trials are not positive in terms of outcome, the trials are so important for science and for understanding what we are treating.
Indeed. So for patients that have normal LV function and coronary disease, we know that heart rate lowering does not change the prognosis, although there may be symptomatic benefit.